Hi, good evening, everyone. My name is Michelle Raslavage, and I'm glad to be your moderator this evening for our presentation, American Indian Healthcare Delivery System, How and Why It Works. And I want to get started this evening with going over a little bit of background information for you from how Indian Health is set up. So I'm going to share my screen. Give me a few seconds here to just get set up. Let's see here. And let me okay, and if one of my colleagues from the panelists can shake your head if you can see my screen, thumbs up, something. Okay, great. All right, so we're going to start out with a little bit of background information, and then after that, we're going to go into our panelists and have some Q&A and questions for them as well. So with that, I want to go over a little bit of background information for Indian healthcare system in our country. So Indian treaties were contracts between the federal and tribal governments. Indian tribes gave up their land in return for payments and or services from the U.S. government. Many treaties identified health services as part of the government's payment for Indian land. The treaties between the United States government and Indian tribes frequently called for a variety of services and benefits to Indian people and includes provision of medical services, services of physicians, provision of hospitals for care of Indian people. And this is what we normally call the federal trust responsibility. The federal trust responsibility is to uphold the treaty responsibility for health care to Indians, and it's accomplished today by consulting with Indian tribes and then actively advocating for advocacy, policy, legislative, and budgetary plans for Indian health care. Back in 1921, the Snyder Act was passed, and it's the basic authorization for federal health services to U.S. Indian tribes. Then in 1954, the Transfer Act transferred the Indian Health Program from the Bureau of Indian Affairs to the United States Public Health Service in what is the former Department of Health, Education, and Welfare, currently known as the Department of Health and Human Services. And this Transfer Act also established the Indian Health Service. In 1976, the Indian Healthcare Improvement Act provided authority for specific directives, programs, and self-determination activities. This one, as we go through the next couple of slides, is important is because it also establishes some of the nursing programs, nursing scholarship programs for a lot of the Native American nurses that go through today. And then last is in 1976, the Indian Healthcare Improvement Act provided authority for specific directives, programs, and self-determination activities. And this last one in 1976, the Indian Healthcare Improvement Act, is important, again, because it'll help tease out the different kind of healthcare programs that are run throughout Indian country. So what is the Indian Healthcare Delivery System? We currently have 574 federally recognized tribes in 37 states. And if this has recently changed, I'm going to let my colleagues or the panelists give us a more current number. There are currently 2.56 million American Indians and Alaska Natives. And in annual patient services, which includes not only Indian Health Service facilities, but also tribal facilities. In the past 2 years ago, there were 40,000 inpatient admissions and over 13 million outpatient visits. The healthcare expenditures per capita for Indian Health Service population patients is a little over $4,000, whereas the national healthcare expenditure per person is a little over $9,000. The total number of Indian Health Service employees is 15,370. Now, this does not include our tribal or urban partners because Indian Health Service is able to get those direct statistics from some of the systems they have set up. There are 2,380 nurses in Indian Health Service, 776 physicians, 798 pharmacists, 270 dentists, 104 physician assistants. And we also have something very unique in that it's environmental health and sanitarians, and we have 195 of those as well. Our next slide shows a breakdown of the number of facilities throughout Indian country. There are, as I point to, let's see here. For Indian Health Service operated facilities, there's 24 hospitals. And if you look at health centers, health stations, those would be considered ambulatory facilities. We have school health centers, there are 12 of those. And there are 6 regional youth treatment facilities that are federally operated by Indian Health Service. But we also have tribal healthcare facilities that are operated by the tribe. There are 22 hospitals, 279 health centers and health stations, or 78. And again, these are more ambulatory. Up in Alaska, they have villages or clinics. There's 59 of those, and 6 school health centers and 6 youth regional treatment centers. And of the 46 hospitals, 5 are IHS and 9 tribal hospitals are critical access hospitals. I try to get as good picture as possible of what Indian country calls our 12 areas, and each area is color coded. You can see here Nashville is the largest geographic area, and we have Beverly Cotton from the Nashville area office. She's the director, who will be one of our panelists, but this is her area. We also have the Oklahoma City area and all the other different colored areas. Then we also have Gerald, who's from the California area right here, and Annie Moon is from this area right here in Navajo. And we can't forget our sisters and brothers up in Alaska, which cover a vast amount of territory as well. And with that, these are just a couple pictures. This is from around the area where Annie's from, out in Navajo. You can see the beautiful canyons here, and this is the Chinle Hospital, and that's me out in front of the Chinle Hospital doing a visit out there. And this is the same map, but overlaid on it are some of the facility locations, different colored dots. The blue dots, I believe, are hospitals, and the white dots are your ambulatory clinics. So it goes all the way from northern Maine, if you can see that. I know this might be small, but way up here in northern Maine is the Micmac tribe. Down to Florida, we got the Seminole tribe and a few other ones. All the way over to California and up to Washington State. And then if you look real closely, you can see some dots peppered all throughout Alaska area. So they've got a lot of health centers and Alaska clinics out there too. This is one of the facilities out in California, the Indian Health Council. And underneath that is one of their clinics out here on the mountainside. And so wanted to take you back, if you recall, the Indian Self-Determination Act that occurred allowed the tribes to have self-determination, self-governance. And so when Indian Health Service first began, these are federally run, federally operated healthcare facilities. But then, again, the tribes now can decide, how do they want to self-govern and self-administer their healthcare services to their tribal members. They're the ones that are closest to the members. They know their needs. They know the high diagnoses of the diseases that are occurring within their communities. So there's a couple ways that tribal organizations are able to execute that. One is they can continue to receive direct healthcare services offered by the Indian Health Service. So if there's a healthcare facility, they say, we still want Indian Health Service to operate it. The second way is for them to use the Indian Self-Determination and Education Act, and they can assume responsibility for their health care formerly offered by the federal government, and they can make adjustments to any of those health services they deem fit that better matches their population's needs. And they can run the facilities themselves, or they can contract back those services to Indian Health Service. And the last way, the third way, is they can fund the establishment of their own programs or supplementation of the ISDEAA programs. And I do know some of the tribes that do that. They augment or they fully fund their healthcare services from their economic portfolios that they do have. And then the third system for Indian healthcare delivery system is in the urban programs. And the urban programs, like the name says, is available throughout different cities throughout the country, Boston, Baltimore, Chicago, just to name a few. But those Indians that live in the urban city have healthcare services that are provided to them either through the facility or they can be referred out. So with that, I'm gonna go ahead and wrap up. This is one of my favorite pictures here. This is home to me when I first started working in Indian Health Service over 22 years ago. It was at Claremore, Oklahoma. And as we go through our panel conversation today, you'll understand and get a little glimpse of why Indian healthcare system works so well and how it works. Right here, this is me. I'm a nurse educator in this role. We also had a nurse practitioner that saw diabetes patients. This is our diabetes care team. This is a pedorthist. She does foot checks. This is a tribal diabetes nurse educator from Cherokee Nation that worked with us. And then we also have a dietitian that it was all part of our diabetes care team. So with that, I'm going to stop. We're going to go on and go to our panelists now for the rest of our time here. Let me stop sharing. Okay. Is my screen down?
It is.
Okay, great. Let me see here.
Well, I'm happy to start with an intro. I'm Gerald Westendorf. I work out at the Tuolumne Miwok Indian Health Center in California, Sonora, right near Yosemite, if you know where that is. And we have two clinics, one in Tuolumne, California, and one in Sonora, California. And I primarily do family practice out there.
Hi, everyone. I am Beverly Cotton. I am the Indian Health Service Area Director for Nashville. As Michelle said, we are the largest geographic territory out of all of the IHS areas. So we serve 36 tribal nations from Maine to Florida over to East Texas. And we also have 3 urban Indian health programs in New York, Boston, and Baltimore. We have mostly tribally operated facilities in the Nashville area, but we do have 5 federal operations, one in Lockport, New York, Mashpee, Massachusetts, close to Richmond, Virginia, Catawba, South Carolina, and then also in Cherokee, North Carolina. So it is wonderful to be with all of you this evening. I'm a member of the Mississippi Band of Choctaw Indians. By training, I'm a pediatric nurse practitioner, and I graduated with my DNP from Vanderbilt in 2014.
Thank you, Beverly. Annie.
Yeah, Annie Moonian chair do Taba Henchlan, Tutness on Bashishi, Ado my dishkizi dasha che do, my dishkizi dashanale. Greetings, everyone. My name is Annie Moon. You know, we were always taught to introduce ourselves by our clans. I am of the Water Edge clan, and I'm born for the Tango People clan. And I was born and raised here on the Navajo Reservation. And I've been here, I started my career here I did my undergrad at Arizona State. I finished in December of '91. A month later, I started here at Chinle IHS. So I've been here, it's gonna be 30 years in January. So I've been here for a long time. I've seen so many providers come and go. So I just stopped making friends because I know they'll leave. Just kidding. So I did the Vanderbilt program in 2002 or 2003. I don't quite remember, I apologize. I moved there with my 2 boys at that time. So I was working at Chinle Hospital for 10 years, and then I decided I wanted to be a nurse practitioner, and then I moved my stuff to Nashville and stayed there for like a year and a half. So before COVID hit, I am the supervisor for our adolescent and school health programs. We go out to 5 local high schools and 3 middle schools and provide primary care to our adolescents and teens out in our community. But since March of last year, we haven't been back in the schools because of COVID, and we were detailed, you know, to help with the epi response since then, and we're still doing that. And there's a few of us, like 5 of us, that are supposedly the SME subject matter experts on COVID. So we're helping with the COVID response, doing anything from patient notification of the results, making sure they're isolated, participating in our daily huddles, lots of meetings throughout the day, just being available for the contact tracers if they have questions, and if patients need any medications. And right now we're doing a lot of community mitigation, and also we're doing a lot of community vaccinations in our at our facility. And then just lots of stuff that I wouldn't normally do. I miss going to the schools, but hopefully we'll start back up in August. So that's me. Thank you. Go ahead.
Thank you, Annie. So for our audience today, we've got a couple topics here we're going to touch base on and kind of go around the table here. The first topic we're going to touch base on is COVID. So Annie, how has COVID-19 affected Native American community so strongly?
Well, it's been a very humbling 15, 16 months. It's been very, very difficult, you know, to say the least, about what's been going on here, not just in Chinle, but the whole reservation. I think the Navajo Nation has long, you know, experienced barriers to healthcare and opportunity. And as the COVID-19 pandemic crossed the country, the Navajo tribe has been disproportionately impacted by the virus. And then, as you have mentioned, you know, we're, I guess, like every patient here, you spent like $4,000, and then compared to the US, it's $10,000 per patient. So we're doing so much more with so much less. And then the Native Americans and Alaskan Natives have 3 times higher rates of COVID-19 and higher rates of hospitalizations compared to non-Hispanic white people. So in May of last year, 2020, unfortunately, we surpassed New York and New Jersey for the highest rate per capita COVID-19 infection rate in the United States. So if you can think about, you know, the whole world, and then there's United States, and then there's Arizona. In Arizona, there's the Navajo Nation. So within the Navajo Nation, there's Chinle, that's where I work, and we have the highest rates per capita, unfortunately. So there are several complex factors that led to the Navajo Nation being the highest COVID-19 rates. So one of them, as you may or may not know from history, that tribes have been particularly at risk for respiratory infectious illnesses. And we know that from the 1918 flu pandemic, and from the 2009 H1N1 pandemic. And tribal communities have more severe illnesses and higher case mortality rates in both of these pandemics, and sometimes, 4 to 5 times higher. And because of the poor healthcare and poverty over generations, now a greater proportion of Native Americans have underlying health conditions, such as diabetes, obesity, heart disease, and that makes them more vulnerable to severe illnesses and death. So that's just part one. There's so many parts to this. And the other part is that there's also limited healthcare infrastructure here on the reservation and technology compared to the rest of the United States. Right here at our facility, we serve a total about 35,000 patients come to our facility and use our facility, and we only have four ICU beds. And for people that are more sick, we have to transfer them to Albuquerque or Phoenix for more higher level care. And then only a small percentage of Native Americans here, of Navajos here, have internet access or broadband services. So you can just drive for miles and miles and not have cell service too. And then there are also cultural factors that we take into account, making the Navajos more vulnerable to COVID-19. So social distancing, for example, is an especially tough concept for us. We live in multi-generational homes. So when one person gets COVID, they come home and then they pass it on to the rest of the family. And it's very common because in a lot of these homes, you have maybe up to 3 generations living under one roof. But to us, it's just a long-standing tradition for our people, to remain together and preserve our culture and heritage. So if you think about people living in overcrowded multi-generational homes, maybe you can have like 8 people living, sleeping in one room. So, from very little children to the elderly. So the housing situations here make it very difficult to social distance or physical distance, if not impossible. And then another factor is many of our tribal members lack basic amenities that most Americans take for granted. There's a good proportion of homes, probably about 30 to 40% of residents that do not have indoor plumbing or have running water in their house. And a lot of our people have to, haul water, not just for their livestock, but for them to drink, their livelihood. So this is a pandemic where the best advice is to keep washing your hands, and they just don't have places to wash their hands, and there's no indoor plumbing, which prevents everyone from being able to wash their hands, as often as recommended. And then the other issue also is just our grinding poverties. 70% of our families live below the poverty level, and there isn't as much economic stimulus on our reservation. So the idea of telling someone, to shelter in place, which would mean like losing their jobs, that's a much harder thing to tell people when they don't have enough money to keep their families fed. So as you can see, all these messages about frequent hand washing, sheltering in place, social distancing, it just didn't work in tribal communities. And these are just some of the reasons why the Navajo Nation, why our tribe became the epicenter of this pandemic. So like I said, it's just been very, very hard to deal with, and we're still dealing with it up to this day. So that's why our numbers were so high here.
Yeah. Thank you, Annie. And once we get to our next segment of this panel discussion, you're going to be able to come back and tell us all the great things that Navajo Nation has done since then to really lead the United States down the road. So we'll circle back around to you, Annie. Thank you. The next question I have is for Beverly, who comes to us from a director position where she oversees, like you saw, that big geographic area, and oversees and works with tribal facilities and the federal facilities. But Gerald, we also have who works at the local level. So we're going to get two different perspectives for this next question. So Beverly, Gerald, whichever one of you want to go first, what did your community do in response to COVID?
Beverly, want to jump on that one and I'll follow you?
Sure, absolutely. So from a federal kind of government standpoint, of course, our key was working in partnership with tribal nations and our urban Indian health programs, in addition to our state and local public health officials and other federal agencies, to ensure that we had rapid deployment of resources, PPE supplies, as well as the critical funding that you saw Congress appropriate to help combat COVID-19. As a result, Indian Health Service was able to provide and administer over $9 billion through the Indian health system to make those resources available to expand vaccinations, available testing, public health surveillance, and additional healthcare resources. I think to Annie's point as well, one piece in Indian Health Service that's often, or a little known fact that's often overlooked, is that there is a big sanitation facilities side of Indian Health Service. So in addition to the direct healthcare services, also ensuring that communities have potable water. So during this COVID-19 pandemic, you've seen Indian Health Service working in close coordination with tribal nations, Navajo Nation specifically, with the amount of remote households that they have, and bringing potable water to those homes. And here in the Nashville area, I think, as Annie mentioned, that most Americans take for granted that water is easily accessible. We have many tribes in the state of New York and Virginia as well that we were working with to expand potable water. I think, Indian Health Service played a central role in ensuring that we had the distribution of critical medical supplies and then PPE from a central standpoint. So that funding that Indian Health Service received from Congress for PPE was then utilized to disperse to IHS, tribal, and urban Indian health programs. The most recent American Rescue Plan is just a historic investment into the Indian health system, with more than $6 billion in brand new funding being sent out to IHS tribes and urban Indian health programs to expand services and recover critical revenue that was lost during the COVID-19 pandemic. So our role is large in the Indian health system. From a regional perspective, we have the responsibility of delivering healthcare, but in partnership with tribes, we worked very, very closely with our tribal nations that operate their own healthcare systems. It was critical for us to get information out rapidly, and then also deploy new testing strategies, PPE supplies, and then of course you saw us in the space of providing vaccines, and I think we'll get to that a little bit later in our conversation today.
Yeah, thank you, Beverly. Gerald.
Yeah, thank you so much, Beverly. And in that similar vein, discussing the amount of support that the tribes received from IHS, I don't think that our clinic would have been able to stay open without that support from IHS and from our tribe. I mean, we were hearing all of these stories about family practices that were closing during COVID just due to not being able to see the number of patients and having to close their doors because of it. And I feel very fortunate to say that we didn't close for a single day. We went almost 100% telemedicine for probably the first 3 months or so, which is something that we hadn't really done before. So that was certainly something that something good that came out of the pandemic, was just our ability to provide virtual medicine via Zoom, telephone, and other means, but we didn't have to close, which was excellent because we're still able to provide that support to not only our tribal patients, but also to the community surrounding us, because we see probably 90% of just low-income community members as well, in addition to providing the support that the tribe needs in terms of their health care. So I just felt very fortunate that we didn't have to have the mass layoffs and the closing of the clinic, because we had that support from IHS. And then as far as our specific response to the COVID pandemic, we really doubled down on our education efforts, not only on the virus, but safe practices such as social distancing, and on the immunization options as they became available. We found that just keeping people informed and helping to quell those fears that were going around with information was really the best way to do it. And we didn't notice much resistance from the tribe, more so than the rural community in general, to those social distancing practices and the mask wearing. I mean, there was obviously some resistance from both the tribe and community, but I wouldn't say that we noticed more from the tribe, but we tried to double down on our education efforts in those regards. And then of course we opened an immunization clinic. We had multiple days per week that we were offering the immunizations, which we will get into a little bit later. And then also we increased the amount that we were communicating between providers. So typically we only meet as providers once a month or so, but we were meeting every week, sharing information, brainstorming on things that we could do to improve our outreach and care, and just facilitating discussion between providers so that we could then bring that education to the community and that support. So yeah, I'm very proud of what we were able to do, and that we were able to stay open with the help of IHS, because I don't think it would have been possible otherwise.
Thank you, Gerald. I think one of the things that everyone pointed out a little bit, and pulling it all together here, is we have Annie, who works at a federal facility, very remote, out in Navajo country. We have Gerald, who comes to us from a tribally operated facility. And we have Beverly, who again is the director over a whole area of Indian Health Service. And there were different components. I think one of the best kept secrets about Indian healthcare is how public health oriented it really is. It's really rooted in public health, because as Beverly mentioned, we have sanitarians and environmental health officers that stepped up, and you could see from the slide presentation the number of sanitarians and environmental health officers that we do have. And then we also had the collaboration between the federal agency, Indian Health Service, with the tribal partnership and your state and local health authorities. So you had all this partnership going on. And then as we transition over to talk about immunization, one part that also may not have been addressed, but as part of Indian health country, is our public health nurses. We have a component of public health nurses. There's also some community health nurses. We have folks that are community health representatives, which are trusted tribal members within the community that people go to. So they have community health representatives, or the community health aid program. You guys may have heard that in other programs from the different parts of the country you're from. So thanks for addressing everything that had been done during COVID and all the collaboration that went on and all the services and programs that you guys have. We're going to shift gears now and talk about immunization. Gerald, what has the immunization process been like where you're at? And has there been much hesitation in your clinic?
Yeah, so I work in the Sonora clinic. We have a nearby clinic in Tuolumne, which is actually closer to the reservation. And the immunization clinic was set up at our Tuolumne location. So that is where we had, I believe, starting off 3 days a week, offering immunizations first medical providers were prioritized, and then shortly after, we made sure that all elders of the tribe that wanted the vaccine were able and had access to getting the vaccine. And then we moved to tribal members, other tribal members finally moving to high-risk groups. And there was, I spoke to the leader of the immunization clinic, the manager, and she said there was some resistance within the tribe, but most of that was combated with that education piece that I was talking about before. And now I'm happy to say that I think about on average, half of the tribe has been vaccinated, which we're very happy with at this point. That's a huge step in the right direction. And we were able to receive the Moderna vaccine in a very timely manner. I believe we were the first in our area to receive vaccination doses, primarily because of that IHS support, as well as PPE and all of the supplies that we needed to administer those doses. Some of the major roadblocks in the immunization clinics were that they were the multi-dose vial. So that was a big one, just finding that we had to use all doses, all 10 doses that were in the vial. Otherwise, we were wasting some. I hope to see as the technology advances that we end up with a single dose that I could give in my clinic. I think that would be a huge step in the right direction as well, because I had patients coming to me saying, hey, when can I get my vaccine? And even though we had doses available, I had to send them to schedule at the other clinic. So, just an extra step that could potentially hinder some people from getting it. The other thing, the other roadblock that we had in an otherwise smooth process was our EHR is a little outdated. We are working on that, but we had to go through our panel individually and find and narrow down our high-risk patients. So that, with over 1,000 patients, that took quite some time to go through, which that's an extra delay. But otherwise, vaccinations at our immunization clinic have been very smooth. And I'm happy with the work that we did in the community for both the tribe and for the rest of the community at large.
Thank you. Yes. So Beverly, across the nation, how are vaccines being delivered and dispersed?
Yeah, so first, IHS and tribal leaders advocated that IHS would be recognized by the CDC as its own state almost. And so with that recognition of IHS as its own jurisdiction, tribes were then able to choose whether they could receive vaccines through Indian Health Service or through their state. And there really wasn't any difference in terms of the amount of vaccine or when they received it. I think the key difference was where did the relationships really rest, and the choice of the tribal nations of who to receive their vaccines from. Once the tribes were able to choose where they received their vaccines, they signed on with their and participated in the CDC COVID-19 vaccine program, and they were able to receive their vaccine directly from the manufacturer. They were either transferred or redistributed from one facility to another. And, I think the distribution strategy of sending it directly to the sites worked really well. But as Gerald was mentioning, some of our sites in the very, very beginning, Indian Health Service was following, of course, the ACIP priority groups for vaccinations. And of course, healthcare workers were at the top of that list. Indian Health Service was very fortunate to receive more than, I think it was 150% of the number that we had submitted for healthcare workers. So we were very quickly able to move through those priorities into from healthcare workers on into the priorities that best fit the needs of tribal nations. And most often those were elders and and culture and language keepers in those tribal nations. But if you can imagine the planes, trains, and automobiles in real life, getting vaccine to these remote locations, especially when in the very beginning, when there wasn't a lot of vaccine and we were sharing, sometimes splitting up the Moderna vaccine, for instance, if you had 100 doses, splitting those up, the vials, there were very creative solutions to making sure that those vaccines made it to the various communities. In one area, even the Coast Guard helped deliver by helicopter vaccines to ensure that every single tribal nation received something at the very beginning. And so I think that partnership between Indian Health Service and tribal nations was at its finest during this pandemic, just to meet the response.
Yeah, I think that's one thing in Indian country you will always find is innovation, because we're strapped for resources, but we always come up with some innovative way to get it done. Mm-hmm. Yes. All right, thank you, Beverly. Annie, since your clinic is very remote, how are you getting the vaccines to your community?
I think for our Navajo area, I think our facilities were, ready to hit, hit the ground running, since we've been preparing since August to receive the vaccines, and we had strategic plans in place already to carry out the vaccine administration quickly and efficiently. So on our reservation, we have what's called chapters, where there's, it's kind of like counties within a state, I guess. That's how I would explain it. And we have 110 chapters throughout the whole nation. And these chapters are kind of like local governments, and each of them serve the people in their community. So we work very closely with these chapters, and each chapter has their own administration, their own staff, and they have what's called community health representatives, CHRs. So we work very closely with the CHRs, getting the numbers of how many patients are in their communities, where they live, and stuff like that. So we work with them. We went out to the houses, to all these remote places, people that are disabled or homebound. We would offer the Johnson & Johnson vaccine to them. And then we also held a lot of community events. We would go out to the chapters, and then set up we have a mobile unit also that we use, which was very helpful. And we utilize that with our vaccine efforts. And then in the beginning too, we also formed our mass vaccination task force, and that consists of some providers, the pharmacists, some medical assistants. So it was more like a collaborative approach, and it worked very well. And we have these public housings also. They call it Navajo Housing Authority, where they have all these houses for low-income families, and we would go out to these NHA housings and set up there and provide vaccines. So it worked out very well. We have really good vaccination rates. Actually, I think we have over 55% of our population, 55 and over. We have like 80, more than 80% of them are vaccinated. We're struggling a little bit with the 16 to 34-year-olds, but our vaccination rates are really, really good. Yeah, so it's been hard, but with all the help that we're getting from other entities, especially the tribal entity, we've been able to vaccinate a lot of people.
Yes, and Annie, from what I recall is Navajo Nation, you guys were the first ones out of the gate to lead the country in immunization coverage for COVID vaccine early on. And a lot of it has to do with the infrastructure you have set up, your clinical information system that you guys have and can pull up those names, their flags, do that high risk.
Yeah, we used a lot of social media also. Our Navajo Nation president and vice president, they did like weekly or twice a week town hall meetings on social media to kind of gain the public's trust, and that was very, very helpful. So they still have those too. So that was really good. And we have the radios, which is really popular. We have one radio station, and they would do bilingual bilingual messaging too. Yeah. So.
Yeah. Well, great. So we're going to move on to our third and final section for our panelists here. It's going to be on lessons learned. So this is open to anyone to go first. So the first question, what lessons do you think we learned this past year, and what worked well?
Oh,
Beverly?
first. Yeah, sure. So, Indian Health in the very early stages of the pandemic developed a critical care response team. And I think that is a huge lesson learned, something that worked really well for us. What we did is develop a national contract, and we had experts that had worked in the pandemic in the very early days in New York and Atlanta that comprised a response team. And then we were able to deploy that response team to either an IHS hospital or a tribal facility to provide training and critical support, not just staffing, but to give the expertise to the frontline workers. And we saw a huge turnaround in those communities in terms of the treatment and the care that Natives were receiving. I think that was a tremendous support in what we've been able to accomplish in the pandemic. I think those types of technical resources and the ability to deploy those resources from a national perspective worked really well for the Indian health system and was a huge benefit to those facilities that really needed that type of expertise.
Thank you, Beverly. Gerald, what would you have done differently from your lessons learned? Which of those would you have done differently?
I think that we did individual patient education really well, but we could have done more outreach to the community at large in the form of education instead of just waiting for that misinformation to come to us to kind of counteract on an individual basis, maybe trying to push more of that accurate data out to the community via, radio or social media. I think that as a clinic, we could have done a little bit more of that. But I think overall, we can learn a lot about just the response that the tribe itself gave in the pandemic, that kind of multi-generational respect aspect, thinking of the community and the group as opposed to just the individual is a huge part of the tribe that I think the rest of the community could learn a lot from that. And the importance of mask wearing and social distancing and protecting your elders, getting vaccinated before you ever think about visiting grandma, that's huge. And I think that's something that tribal members did well that maybe not the rest of the community did as well. So I think that's a big lesson. And then also just pushing out that education to the community a little bit more, I think. And also getting a different EHR, which we're hoping to update by the end of the summer. So I'm excited for that.
Well, I think all things considered, we're drinking out of a fire hose.
Yeah.
And so trying to keep up with what education looked like, what do we deliver to them? So I'm sure you guys did a great job out of the gate. Beverly, were you going to say something?
I was going to say, with that new ARPA funding, just the huge opportunities that we have to modernize the health IT system within the Indian health system is going to be a huge benefit because, as Gerald mentioned, that was a huge limitation for us in responding to COVID, and then having the data and everything that we need to know where our trends are, our hotspots. A lot of work went into making sure that that information was readily available.
Thank you for that.
Oh, sorry. I think
Go ahead,
I think
Amy.
for I apologize. I think for us, what worked, what went well immediately is our contact tracing. We implemented contact tracing from the start, and our models show that that as a result of our contact tracing, specifically to Chin-Li, I'm pretty sure as we apply it broadly, it really did prevent a lot of hospitalizations and death. And, you know, even though it was horrible, what we experienced here, I think it would have been much worse. And we have the evidence to show that. And at least for Chin-Li, so that went really well. And we were able to expand our staff to continue sufficient level of contact tracing efforts. So I think that worked very well for us.
Excellent. Thank you, Annie. So we're going to start wrapping up here. We had some questions that were submitted to us prior to the presentation today. And one of the questions was, I would like to work under the Indian Health Service. Can someone address the difficulty in navigating the application and hiring process for nurse practitioners? So I want to call out that there's going to be a panel of alumni discussing loan repayment programs. That presentation will be July 8th at 6 p.m. Central Time. And there should be details coming in the next week or two, so you can sign up for that and join that. But until then, did anyone want to say a few words about the application process?
Well, just to go back to your first presentation, one thing that blew me away was the amount of nurses employed by the IHS as opposed to any other group. I mean, triple any other group, which I thought was amazing. And I myself did not have much more difficulty applying for this position at the Indian Health Clinic than I did any other position. So I don't know if, I mean, that's very anecdotal, but I didn't have much difficulty getting this position, but I feel very fortunate that you know, was fairly easy for me. And as a recipient of the NHSC loan repayment, not IHS, but I think that my application was given more weight because I worked for Indian Health, an Indian Health Clinic. And I also do know that an extra $15 million was given to specifically fund clinicians that worked for Indian Health within the NHSC program. So I'd say if you're looking into a position with an Indian Health Clinic, or you already work for an Indian Health Clinic, both the IHS loan repayment and the NHSC are wonderful options for that extra repayment.
Thanks, Gerald. And NHSC stands for the National Health Service Corps, which is administered under HRSA. And I drew a blank on what HRSA, HRSA stands for, the acronym. Can anyone help me here?
I believe it's Health Resources Services Administration, I think.
We've worked in
That's
the
all right.
government long, we're all acronyms, just like some of our clinical language we use. So thank you. Yeah, so again, like Gerald said, the National Health Service Corps application process will be presented during that July 8th presentation. Another question we had submitted, what is the best way to help on a volunteer basis?
So we do accept volunteers in the Indian Health Service. Each IHS area has its own recruiter. So I'll actually, how about I plug into the chat the link to find an area recruiter, and you'd reach out to them, let them know that you'd like to volunteer as a provider or in any other actually aspect, and they can help connect you to the right person. I would encourage you, if you don't hear from someone right away, be diligent. We need volunteers. We love volunteers. There is a process to go through your background checks and all of those pieces, but right now there are some special authorities for volunteering to provide vaccines. And we do have a much more streamlined process. So I'll drop that link in the chat for everyone.
Thanks, Beverly. We had another question, is adequate credentialed diabetes education available to all who need it? And I believe if I understand this question correctly, for clinicians who work in Indian country, do you have a good opportunity to get diabetes education? And I will say, yes, you do. You will not only get continuing education, you will get hands-on education, because diabetes is one of the highest diagnoses in Indian country, that there's no way you can leave Indian country without knowing, I would say, even a advanced beginner level knowledge base. You will not come in, I mean, you may come in as a novice, and depending on how long you stay, you could leave as an expert. So no matter where you work in Indian country, you will have opportunities. And as a matter of fact, it used to be called the American Association of Diabetes Educators. They did collaborate with Indian Health Service several years ago, more than a decade ago, to help construct education programs delivered to clinicians that worked in Indian country, because it was hard for clinicians to either take off work, travel, and so they have developed educational programs online that are available at no charge with that collaboration in place. And we have another question that was submitted from one of our attendees. What are the current trends in healthcare within the American Indian healthcare delivery system? Beverly or Gerald?
I would say just real quick that one trend that I'm seeing is just that modernization and increased ability to provide care and meet the patients where they're at via Zoom, other telemedicine, improved EHRs, just encompassing the power of technology and using that to facilitate care. I think that our clinic is certainly moving that way. I can't speak to the overall American Indian healthcare system, but on a local level, we're certainly moving in that direction to really take advantage of that advancement and help provide better care to our patients.
Thank you, Gerald. And let's see here. With that, I'm going to go ahead, and we are coming to the hour of our panel discussion here. I want to thank everyone for attending and participating with us tonight. I do want to call out that some of you may have seen a Vanderbilt magazine article earlier this year about the School of Medicine with Jill Moses and our own Annie Moon working and fighting COVID-19 in the Navajo Nation. And the Vanderbilt Nurse magazine has the full story, and it is in the new Alumni magazine that should be arriving in your mailboxes next week. So Annie, thank you and congratulations. And look in your mailboxes for that Nurse Vanderbilt magazine. And on behalf of everyone, I want to thank Beverly Cotton, Gerald, Annie. Thank you for such great information sharing with our colleagues. Appreciate it.
Thank you for
everyone. Have a good evening. Oh, you're welcome. Yeah. Everyone have a good evening, and we will see you later. Bye-bye.
Thank you.
Thank you.